Good evening, everyone. Thank you for joining us for tonight's webinar, Living with Lung Cancer, organized by the Florida Society of Clinical Oncology. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals participating in this webinar are FLASCO members, and we're grateful for their support. My name is Dr. Terrell Johnson. I'm a medical oncologist at the Orlando Health, UF Health Cancer Center, Orlando. I'll be serving both as moderator and presenter for tonight's webinar. Our oncology experts and I will discuss lung cancer and treatment options, as well as more individual focus areas, including support for caregivers and patient advocacy. We'd like to thank Foundation Medicine for sponsoring this webinar and making it possible for us to share this important information. Before we begin the presentations, I'd like to let everyone know that this webinar is being recorded so that those who were unable to attend can view it at a later time. Also, your lines will be muted for the duration of the webinar. Toward the end of the meeting, we will host a Q&A, and we encourage you to submit questions or comments via the on-screen question box on GoToWebinar panel. We will discuss as many questions as time permits. I'm honored to introduce our accomplished group of panelists for this evening's webinar. I will briefly introduce them now, but please read their impressive bios in the meeting packet that was emailed to you. The link to download the meeting packet is also in the handouts box on your GoToWebinar panel. Our first panelist, Dr. Rami Manochakian, is a thoracic medical oncologist at Mayo Clinic, Florida. He is specialized and developed expertise in treating patients with thoracic malignancies, including lung cancer. Also joining our panel is Alexia Zadok, an outpatient stem cell transplant social worker at the University of Miami Health System Sylvester Comprehensive Cancer Center. Our final panelist is Dr. Michael Diaz. Dr. Diaz serves on the executive board of Florida Cancer Specialists and Research Institute and as the assistant managing physician / vice president. Also serves as FLASCO's director of patient advocacy. Thank you, panelists, for joining us to share your insight on the mechanisms behind living with lung cancer. We'll begin our presentations with a quick overview of the diagnosis of lung cancer, staging, and treatment of early stage lung cancer. So, just a couple of quick words about early stage lung cancer. We know that in the US, there are about 820 expected cases of cancer for 2020. Unfortunately, Florida has the highest percentage of those cases, with about 18,150. This is second only to lung cancer at about 279,000 cases. Florida has one of the highest mortality rates for lung cancer. This is about 2.5 times the number of mortalities that we have for colorectal cancer. So in Florida, we want to be vigilant about giving people information about early stage lung cancer and mechanisms for early treatment and diagnosis. On a positive side, lung cancer most recently has had the steepest decline in death rate of all cancers since 1990. 5-year survival has increased. Our survival with localized, regional, and distant disease has also increased. Lung cancer research only receives about 10% of the dollars that are spent towards cancer infrastructure. So what we know is that we need to increase knowledge and options for treatment. One of the most important things I can tell you about early stage lung cancer is that we need to increase knowledge and information on lung cancer screening. We need people to speak with their physicians and their peers about lung cancer screening. When we say lung cancer screening, what do we mean? We mean that in people who are ages 55 to 80, who have a heavy smoking history, most would say that's at least 30 years, meaning a pack a day for 30 years, who are current smokers or who have quit in the last 15 years, these people should be screened with low-dose CT scans. The radiation dose for the CT scans is very low, and the hope is to find cancers prior to having symptoms. What we do know is that if you aren't in this category, that screening is probably not as beneficial and can lead to some unnecessary testing. But in patients who fit these qualifications, our hope is to increase our ability to find early cancers and thus get those patients treatment early before they develop symptoms. The second thing is, despite lung cancer screening, we also want to continue to be very vigilant about smoking cessation. It's important, even if you're getting screening, to help people with smoking cessation, as this is one of the most effective tools that we know to decrease our incidence of lung cancer. However, if you do develop symptoms, we want people to know about the symptoms that you can experience. You can experience persistent cough, hemoptysis, sometimes chest pain, sometimes hoarseness, sometimes lack of appetite, shortness of breath, and then sometimes fatigue or unexplained weakness. If you do require lung cancer treatment for early disease, treatment options can include surgery, radiation therapy, chemotherapy, and targeted therapies. We know that this is best done in a multidisciplinary fashion, and so we encourage people to seek treatment at well-established centers that can help you through this treatment journey. So those are some of the points that we want to make about early treatment of lung cancer. We want to focus on what you can do if you have more advanced lung cancers. We will now ask Dr. Manachakian to turn on his webcam and share his presentation, Management of Advanced Lung Cancers.
Thank you, Dr. Johnson. Are you able to see me and hear me well?
Yes.
Okay, excellent. Thank you very much for the FLASCO committee and for Dr. Johnson for having me on. It's an honor and pleasure always to be in these wonderful lectures, especially when it's a lecture for or a conference or chat with that is dedicated to our patients, which are who are the ultimate reasons of why we are all here. My name is Rami Manochakian. I'm a medical thoracic oncologist at Mayo Clinic, Florida. I am my areas of interest and specialty, so to speak, is thoracic malignancy and in particular lung cancer. I'm going to try in the next kind of 15 minutes or so just to touch base and in general about options for lung cancer patients, especially those who have advanced lung cancer. I'm happy to take a lot of questions, during or after. Ultimately, again, as you could notice, Dr. Johnson and I and the other panelists are, really trying to do in a very informal, presentation, just to get kind of give everyone the major, overview of lung cancer. Advanced lung cancer, the one part that I'm going to focus on in particular is what we call the late or metastatic or stage 4 lung cancer. These are different terminology that you may hear from your doctors. Lung cancer, as a matter of fact, compared to most other, if not all other types of cancers, is notoriously known to be diagnosed at a later stage. As a matter of fact, about probably 50 to 60% of patients with newly diagnosed lung cancer, they're actually diagnosed at a stage 4, meaning the cancer has already spread in different areas of the body. Stage 4, meaning the cancer started in the lung and has spread. There are different things that could make a cancer a stage 4, mostly if the cancer is outside the lungs, in other organs such as the liver, bones, brains. Sometimes cancer is called stage 4 if it started in one lung and went to the other lung, or it went to the layers outside the lung. A lot of my patients, ask me, what do you mean we have a stage 4? Until a month ago, 2 months ago, we were feeling well. We had a scan a few weeks ago or a few months ago, and for different reason, and it was okay. Was it missed or what happened? Well, it's a long conversation that we get, but the reality is that, as I mentioned, at time of diagnosis, cancer already is at an advanced level. When somebody has a stage 4 lung cancer, it becomes what we like to say probably incurable. We never say never, and I'll be touching base, and I'm sure Dr. Johnson as well, about how where the science nowadays has led us, and how it's a very, very hopeful era for cancer patient in general, lung cancer in particular. Of course, people may say I'm biased, or our panelists here, because this is what we do for a living. We treat lung cancer, but it is actually a reality that over the last 4 to 5, 10 years, and moving forward, we've changed the way we treat cancer for good, and there's a lot of hope and a lot of advancement for patients with lung cancer. Nevertheless, when the cancer is spread, it means it's spread through different ways, usually in particular through the bloodstream, and it becomes a very difficult cancer to cure. We use the word cure for patients who are alive despite having a diagnosis of cancer after 5 years, and have hopefully minimal disease or no disease. Again, we never say never, but the odds of eliminating or curing stage 4 lung cancer is low. However, it has become, especially lately, a very treatable cancer. And one of our goals, and the goals of this major medical societies and researchers and clinicians, and led by ASCO and FLASCO and others, is that, okay, we put too much pressure on cure, but if we cannot cure the cancer, we would love to cure it, but if we can we turn it into a disease we could live with? And I think the title of this webinar couldn't come any better: living with lung cancer. I think it is a success if we can live with lung cancer, and fight lung cancer, even though we may still have the disease, but actually be able to live with it with a good quality of life, and with the disease as maintained as controlled as possible. How do we treat stage 4 lung cancer? How can we, potentially control it, live with it, and hope that we can cure it? Well, because the cancer at a stage 4 is spreading through different areas of the body, we need to attack the cancer not just in one area. As Dr. Johnson may have mentioned earlier, if you have an earlier stage cancer, stage 1, 2, maybe 3, you have the cancer mostly in the lung, you can go and do what we call a local therapy, surgery, radiation therapy, and so that different modalities and so forth, and which I'm not covering now. But I wanted to use that to say, well, for stage 4, that rarely, works. There are certain circumstances that we may consider, but you need something that going after the cancer everywhere, and that needs to be medication, needs to be drugs, or what we call systemic therapy. And systemic therapy for years used to be simply what people refer to as chemotherapy. I am sure every person attending here or every person we know of, there's not a single family who's not hit by cancer one way or the other. And historically, we know for years and years and for decades, chemotherapy have been and continue to be, or has been and continue to be, a major treatment modality for stage 4 lung cancer. Well, I'm going to touch base a little bit about chemotherapy, but then I want to talk more about some newer, more promising and better agents for different reasons, or better modalities of treatment. But chemotherapy, or what we use a scientific, very fancy terminology, cytotoxic chemotherapy. What is cytotoxic? Again, I don't want to use some medical jargon here, but it's important to know where the terminology came. It means basically toxic to the cells, because it kills the cells. Chemotherapy are given mostly, majority in an IV, an infusion through the veins. They are given in so many different types of cancer, including lung cancer. And these drugs are going into somebody's bloodstream and into the system with the goal of attacking the cancer, killing the cancer cells. Success rate varies, or what we call the response rate, meaning are we able to shrink the cancer or maintain the cancer as stable? The failure would be if the drug, if the cancer continues to grow while, we're still on chemotherapy, or while we're on chemotherapy watch. The issue with chemotherapy, as many of you probably know, and probably many of our folks attending today have received chemotherapy, I like to say chemotherapy is not smart. Doesn't kill only the cancer cells, is not always able to differentiate cancer cells from normal cells. And as a matter of fact, any cells that grow fast in our body get attacked, by chemotherapy, such as our blood cells, the bone marrow, which is the factory of our blood, get hit by chemotherapy, so it doesn't get very functional and it doesn't make enough blood cells, or it actually slows down in making blood cells. So people could have low blood counts, could be a risk of being anemic, more tired, more short of breath, and whatever anemia could, symptoms could bring. White cell counts, the cells that fight infection, can go down, so people could be at a higher risk of infections. Platelets, the cells that keep us from bleeding, can go down, so there is a risk of bleeding, and so forth. The lining of our gastrointestines, organs, of our esophagus and stomach, they tend to grow fast, so they actually get hit by chemotherapy, and that's why patient could have nausea, vomiting, diarrhea, constipations. Hair loss, again, our hair grows very quickly, so hair loss is a common side effect. Affecting the nerves ending, not having what we call neuropathy, generalized fatigue, muscle pain, and the list goes on and on. I don't want to spend the day going through it. And these side effects are important to know and to be aware of. And I always tell my patients, we don't want to scare you of these side effects, but we want you to be aware. As a matter of fact, majority of patients experience mild to moderate side effects that we are able to manage through and walk through. And one of the advances of the science over the last decade, not just the new cancer drugs, actually new supportive drugs and supportive measures that help our patient tolerate treatment better, better medication for nausea, better medication for appetite, better medication to prevent a reaction to the chemotherapy, and so forth. So definitely we have gone a long way in being able to give these aggressive cytotoxic, now you know what it means, chemotherapy but have the patient be able actually to tolerate it. Nevertheless, chemotherapy is still not the most successful. It works for some patients, but it doesn't work for many patients. There's a lot of science, a lot of studies looking into which patients are more or less, more or less sensitive to actually respond to chemotherapy. But the reality is really this new era of fighting cancer that we live in nowadays, it's really because that we realized that only with chemotherapy we're not able to actually cure cancer or control cancer, and we need other things. Chemotherapy still a major backbone of cancer treatment, and even in the upcoming few other treatment I'll be mentioning in seconds, sometimes chemotherapy still plays a role. So we spoke about number one, chemotherapy. Number two is actually a newer modality of treatment. It's called immunotherapy. It's something that the science and the scientists have been looking into and exploring for years and years. And finally, a lot of great research came to fruition over the last decade, where actually we have drugs that helps boost our own immune system to attack the cancer, to kill the cancer. It was always, fascinating, and the scientists were always looking at, since the cancer are kind of a foreign, entity attacking our body, why is our immune system is not attacking it? And years of research and decades of research was able to prove that actually our immune system would like and is trying at times to attack the cancer, but there are different ways and mechanisms where the cancer actually block that attack or breaks that attack. Cancer is sneaky, cancer is malicious, cancer is malignant. It knows how to actually bypass our immune system. So these new drugs, actually, there are commercials everywhere. You see them now on TV, see them in the airport, you see them everywhere, which is not something we are used to, where really the cancer drugs are actually being, in commercials like that. But it's because of how actually, intriguing and how promising they are. And so these immunotherapy, what they do, they work through a different mechanism of action. But to try to simplify it, as I mentioned earlier, when our immune cells is starting to actually attack immune system or immune cells, attack the cancer cells, the science has shown that there is actually some bonding through different special proteins and receptors that actually sits on the surface of the cancer cells and the immune cells. They actually bond with each other. So the immune system is no longer attacking the cancer cells, but rather is actually the cancer cells is introducing itself more like an ally. We bond with each other. Again, I'm trying to simplify it. The science is more complex than that. Well, what this immunotherapy does, it actually comes and prevent that bonding. It attacks or it blocks those receptors or those protein. So all of a sudden, the immune cells is not able to attack the cancer cells is not able to identify itself to the immune system as an ally. It's actually now the immune system is realizing, what is this? This does not belong here. Let me attack it. And again, it's doing this because of the boost that it was given by the immunotherapy. Immunotherapy also are given through the veins. They do share the same side effect or possible side effect of chemotherapy, because they could still attack some of these cells or have our immune system attack other normal cells. But the good news is that across the board, they're better tolerable than chemotherapy, and it's less likely to have a major side effects that are life-threatening or lead to us stopping the drug. It's not 100% safety. As a matter of fact, there are some side effects, and there are some patients that we need to stop the treatment, and not a high percentage, but basically due to some immunological reaction or inflammatory reaction because of the way the immune system is attacking the cancer cells in the body, we could have some side effects throughout the body. Again, I don't want to cover them, but it actually, overall being very well tolerable. Now, I can tell you why it's exciting. Well, it's not just because of the concept, but because this immunotherapy has been compared to chemotherapy in lung cancer and actually in many other cancer. And it has shown that in good percentage of patients who meet certain criteria, we check certain patterns, check certain proteins. Actually, immunotherapy is more effective than chemotherapy. So in some patients, immunotherapy more effective than chemotherapy, and I just told you earlier, even better tolerable than chemotherapy. So that's a double bonus, right? We wanted a drug that works, and also the body can tolerate it better. The other thing immunotherapy is doing is when it works and if it works, and there is a big if, which I'll cover very shortly, it actually, in very good percentage of patients, it's actually working for a long time. And for the first time ever in the history of lung cancer management, we have seen over the last few years that the 5-year survival rate has gone significantly up from a very few percentage of patients with stage 4 lung cancer who are able to achieve a longer term survival to a higher percentage, maybe not by much, but it's still a very reasonable baby step at a time. And some report list that in the 15 to 20%. Now, the science dig deeper and say, well, how about I still want to do some chemotherapy because it may help, and I want to do immunotherapy. Maybe they could work together. Indeed, in certain patients, again, everything I'm telling you today does not apply for every patient or every one of you or your family member or friend. This is why the discussions are important. We live in what we call an era of individualized medicine, personalized medicine, treatment. Two people may have the same type of cancer, the same advanced level, but we are treating them differently due to a different biologic markers and so forth. So actually, there are patients who benefit from combination of chemotherapy and immunotherapy together, and it has shown that it actually could help them, longer term. Immunotherapy, just like chemo, is not working for everybody. As promising and as exciting as it is, more patients, believe it or not, do not benefit from immunotherapy as opposed to other drugs. And this is what the science now is trying to figure out. Okay, what is making this patient or this cancer responding to immunotherapy? Most of the clinical trials, all of the panelists today are involved in different clinical trials and in different academic institutions. They are doing an amazing job, is looking into, okay, can we try immunotherapy with something else that could make the immunotherapy work better? Or if we start immunotherapy and it stops working, or it works then it stops working, can we combine it with something else that could help, and so forth. Plenty of clinical trials, thousands of clinical trials nationwide and internationally, looking into what is the next step, what can we do better, and we know that the future is looking very promising. Last topic I'm going to cover briefly is, we talked about chemotherapy, we talked about immunotherapy, then comes what many believe is actually the major change in the way we treat lung cancer. It's the breakthrough of treating lung cancer and many other cancers, something called targeted therapy. And as the name implies, it's a targeted therapy. It's something going to attack a particular target. We talked about chemotherapy attacking everything. We talked about immunotherapy, maybe is a little bit more targeted, but it is in general having our immune system attack the cancer. The targeted therapy is actually going after special genomic changes, okay, at the level of the cancer cells. My patient often confused it or tell me that, do you mean it's something in our family or our genes? And I want to differentiate that. It's not. It's actually, we check the DNA of the cancer cells and we check for certain mutation, which are changes, something that messed up the DNA. As we know, the DNA is drive the growth, drive what the cells would look like, drives what the cell will do. And when there is a change in that DNA, that leads to special protein or activation of a special enzymes or substances they're actually believed to be the driver of the cancer growth. So, it makes sense. It's logical. If we are able to attack that protein or that genomic change, so we can block that effect and block that protein from driving the cancer, wouldn't that, stop the cancer from growing or shrink the cancer? Absolutely. So, very long topic. We could talk about it for hours, but right now, as we speak, as of today, we have 7 and more coming actionable mutation or changes in the DNA of the lung cancer cells that we have proven that they drive a cancer growth, and we have special drugs for. They're called targeted therapy. We have 10 to 15, maybe more, FDA approved drugs that are actually specifically prescribed for these patients who have these, who their cancer harbor these mutations. What's the percentage of these cancers having mutation? It's not very high, but it's still there. Putting all of them together, there is about 25 to 30 of patients at least that we are able to find one of the mutations. Some mutation, believe it or not, they only exist in 1% of patients, but that 1% could be you, could be me, could be my mom, could be my family, could be my neighbor. So we definitely need to know if that mutation does exist. The most promising news is that in the horizon now, we have actually more mutation that we are able to pick up that actually have some drugs in the pipeline, where I envision, and I'm sure my colleagues here would agree, that 5, 10 years, 20 years from now, we are treating most cancers, every cancer, based on their actually genomic testing. These drugs comes in pills form, which is another advantage, not coming to the clinic and getting the IV infusion. They're fairly well tolerable, but they have their own fair share of side effect, which again I don't want to cover, but they tend to be fairly tolerable with some unique different type of side effects. And they also work very, very well. As a matter of fact, they are the most effective cancer drugs we have. If a patient has a mutation, a very famous mutation, don't want to overwhelm you with the science, called EGFR mutation, the pill that we have has 70 to 80% chance of shrinking the cancer. This is something unheard of in the history of cancer management. Chemotherapy at best have a chance of 30% to shrink the cancer. It has another chance of stabilizing the cancer, as I mentioned, which also would be relatively good success. But to be able to shrink the cancer, so it makes sense, and it's exciting because you're actually hitting the cancer cells with a special targeted therapy that mainly and only attacking that target. But here's the caveat: you can only get this drug or give this drug if the mutation exists. And if the mutation doesn't exist, they're useless. We don't even prescribe them. We're not allowed to prescribe them. Then we go to the other chemotherapy, immunotherapy, or so forth. Again, we have just last 3 months, we have 3 new FDA-approved drugs in lung cancer, stage 4 lung cancer, for those who carry certain mutation. I expect in the next few years we're going to have more, and already the science is looking what is going to be another question. Well, these drug works very well, but at some point they stop working for many patients, not for everyone. We have, all of us here in this panel, we've witnessed patients. I have patients with me who've been going on for years and years on these drugs. But the reality is, majority of patients at some point, the cancer find a way to become resistant, sneaky, malignant, malicious, to become resistant to those drugs. But the science is trying to get ahead, and already we have some drugs that actually we could give if the cancer progress and move on to the second line and so forth. So you may we speak with passion about this because we know that fighting cancer is not easy. Let alone lung cancer, the most cancer killers, as Dr. Johnson shared with you. Lung cancer, despite everything happening, kills more combined than colon cancer, prostate cancer, and breast cancers. We know, the next few years, so much hope. I know for a fact that the number is going to be better. We know there are more patients going to be living, but definitely we want to make sure we're putting all the fight together, as Dr. Johnson mentioned, have all the expert together. That's why treatment at a very good centers, where the providers are going above and beyond to coordinate with each other in a multidisciplinary fashion to try to provide the best possible treatment. Be available to test for these mutations. Remember those mutations I just mentioned to you? I mean, those is not something we can pick up just in a simple blood work. We can pick them up in some blood work, or preferably in the cancer tissue, where those need to go through a special test, through special testing, that you are able to find the mutations. It takes time. The science now has shown that actually, if there are enough cancer cells in the blood, we can check them in the blood. As a matter of fact, we recommend for every patient with stage 4 lung cancer to have their cancer genes check in the blood and in the tissue. But that requires more science. That requires more coordination, more effort, and more research. But I personally, and I'm sure the panelists as well, I'm very hopeful. I'm very optimistic. We try to be part of the fight. It's very difficult to fight cancers. Every cancer patient, I always say every cancer patient, they're very, very special. They fight with their blood, their souls. And the good news, at least, there is more we can do. More we can do together with these drugs, with these scientific advancements. We're hoping one day, whether with lung cancer or other cancer, we can say, we're curing cancer, we're conquering cancer, which is a major, motto for ASCO and FLASCO as well. Thank you for giving me this opportunity. I'm going to stop here. I may have gone a little bit longer than my time, but definitely a very long topic. I'm going to turn it back to Dr. Johnson and the other panelists, but I'll be sticking around for any possible questions. Thank you.
Thank you for sharing your valuable perspective, Dr. Manashakian. I'd like to remind all the attendees that if our presentations brought up any questions you'd like to share with us, please type them in the questions box, and I'll read as many as I can during the Q&A portion towards the end of the webinar. Next, we'll hear from Alexia Zadok, who will turn on her webcam and discuss patient assistance programs and caring for the caregiver.
My name is Alexia, and I am a social worker at the University of Miami Hospital in Miami. And we're going to talk about a few things. We're going to talk about what does a social worker do, some financial support, and community resources for patients and caregivers. So every hospital has a social worker, and every patient and every person should have a social worker assigned to them at a hospital, even if you don't know it. So you do not get discharged from a hospital without a social worker looking at your case or your situation. You just might not meet them all the time. So a lot of the times when you're in and out, there's actually social workers who are helping you. You're just like unaware of what they're doing. So a lot of the time what we do in the hospitals is when you get discharged, we make sure that when you're being discharged, you have everything you need to go home. If there's medication that's recommended, you have the medication. If there's any durable medical equipment to help you, like walkers or canes, wheelchairs, we help get you those resources. And a lot of the time too, a lot of people do not know this, but you can ask to speak to your social worker, and we can help you arrange transportation to visits. If you don't have transportation, we can help with high co-payments for medications if you can't afford your co-payments for your medications. And we can help also with short-term housing. So there's a lot of things that social workers can do, and a lot of resources that we have that patients don't know. They have no idea how much work and how much resources that we actually have. So if it doesn't hurt to ask to speak to your social worker, because she can have it or he can have a resource that you don't know exists, or even know that it's something that we can do. So it's very helpful to find out who your social worker is at your hospital and ask to speak to them and get connected with them. So during this time, it's really hard for patients to manage their finances and figure out what's going on, and it can be overwhelming to go through everything all at once. So what we recommend to do is always ask to, besides speaking to the social worker, there should be somebody from billing or a finance department at the hospitals who can help you deal with insurance issues that you may be having. So for example, I had a patient today tell me, I have labs that have to be done and they're not being covered by my insurance, but I thought my insurance covered it. So I message finance checks it, and they find out that you're being billed incorrectly, and then they can correct it and help you get your bills covered. And if you have to pick an insurance, it's important to ask to speak to finance and billing in the department, because they can help refer you to an insurance plan or to a company that covers your doctor and covers the medication and the treatment that you're going to need. So it's really important to also speak to the finance people wherever you're receiving treatment. If you need extra help going through bills and organizing yourselves and actually come up with a finance plan, the Cancer Support Community Helpline, which on the Cancer Support organization sheet that we've attached, there's over 13 organizations there. So I'm going to throw out some names, and it might be a lot of information for all the companies and organizations that I'm going to reference. But you have that paper, and I would take a screenshot or take a picture of it and save it and go through all of those organizations. Flasco itself, like, that's where you start, because they're going to be able to connect you to other organizations, and they have all these resources on their websites to help connect you to services that you may need or that could be very helpful to you. But the Cancer Support Community Helpline Service, which their phone number is on the Cancer Support organization sheet, if you give them a call, they'll assign a financial case manager to you who can speak to you and help you, budget yourself and get ready for treatment and coming up with like a finance plan. So they help too with short-term cancer coping assistance, with short-term housing resources, and for treatment decision planning, and for financial navigation regarding the cost of cancer and treatments. So it's a lot of information, a lot of names I'm going to throw out, but that one page with all of the icons for all of the different organizations is the first place to start. It could be overwhelming when you go sometimes to someone's website and there's just a whole bunch of information, and it could seem like it's a lot being thrown at you. So I always recommend to give them a call. Every single website has a connect with us, and if you give them a call and say, hi, my name is X, Y, and Z, this is my diagnosis, this is what I'm going through, what can you do to help me? All of them will tell you, okay, this is what we have, or they'll be able to refer you to people who can help you. So every cancer support organization that's on their sheet that we've attached, they help with financial resources, medication. They could help with transportation and short-term lodging. Sometimes we have patients who have to drive over an hour to their hospital to get treatment, or you have to go 3 times a week, and that's a lot of driving. And we can help apply for different organizations that are on here that can give you gas cards, or that will pay for hotels or give you free hotel stays at the hospital that's near you. So these are very, very helpful. For lung cancer specifically, the Go-To Foundation for Lung Cancer is extremely helpful with resources and support for patients and the caregivers. The Lung Cancer Research Foundation, they always keep their website updated, and they have a bunch of information in there also on resources. And it's important that we take advantage of these resources, because it's good to be aware of what's out there before you start. So while you're going through your treatment, you're not feeling overwhelmed. You know exactly who to go to for which assistance you may need, and to plan it out accordingly. 4 of these organizations could all provide transportation, but you don't want to use them all up before your treatment, because you're going to have a lot of follow-up appointments after treatment or during treatment. So it's important to calculate who's offering what and when to use it. If you go to a certain organization and they tell you, sorry, we have no funding right now, nothing's available, you try again the next week. Things open up all the time. So don't get discouraged if they tell you, sorry, we can't help right now, because there's always another week and there's another day. So each organization also has their own guidelines, which is why I say it's very important to give them a call. Some of them, it depends on the diagnosis, and it depends on the age for what is available for you. A lot of these organizations also provide support not only to patients, but to caregivers as well. So it's important that you join a support group if you're a patient or if you're a caregiver, because you're both sharing this experience, but obviously going through you're seeing this through different eyes. As a caregiver, you're carrying a lot on you, and a lot of the time, a lot of caregivers will put their family's needs before their own, whoever the patient is, before their own needs. And they neglect themselves and forget themselves, and they can get burned out. And you can't help someone if you're not helping yourself, and if you're not 100% okay. And sometimes we have patients who come in and they're trying to be the strong ones, and they're trying not to, show their feelings, and it's hard for them to feel like they have someone to vent to because their caregiver doesn't understand what they're physically going through. And it's a lot. So there's tons of support groups where you can, if you, right now because of COVID, we don't recommend anyone going to a support group that's in person, but there are virtual ones online where you can FaceTime in like this, and you can video chat, or you can give them a call. Organizations like the Go-To Foundation, if you call them, you can talk on the phone with them, and they'll take your age, your name, your basic demographics, and try to match you and pair you with someone who you could talk to who went through something similar to what you're going through. So you have someone to relate to. So whatever type of support you're looking for, even if you want to be anonymous, it's out there. So for our families and our patients and our caregivers, it's really important that you figure out who is your support system. Who can you call, who can you rely on, and who's responsible to help. And I know personally, I was a caregiver for my dad, and he had cancer, and it could be really hard to hand the reins over or to ask for help, because you know your loved one best, and you know what they like to eat, how they like their clothes folded, everything. So you always feel like, no, it's just easier if I do it, but it doesn't help you, and it doesn't help them. If somebody offers to help, it's important, and it's really hard to say yes, thank you. If you're part of a church or any other religious organizations, that could also be a very helpful, support team. We've had a lot of patients say, like, just people from my church just dropping off food can help, or people can volunteer to help create a schedule for appointments so the caregiver can go grocery shopping. But there are also apps now that help a lot. So if you don't want to leave your house because you're helping your caregiver, you have an appointment, you could always order your groceries off Instacart or for pickup with Walmart. There's a ton of options now with technology that could help reduce stress and, activities and things that are put on your shoulders. So something that I recommend a lot too is to have some frozen meals in your freezer to help on those really busy days where it's just too much, into meal prep. And this can help reduce, stress when you're having a really busy day. And it's something that's not complicated, and it's something to make it easier. But it's really important that the caregivers learn to delegate. So if you have a teenager, it's time that you teach them how to do laundry and tell them to clean the kitchen. But it's really important that for caregivers, you find at least 30 minutes a day to do something for you. If it's going on a walk and being by yourself, if it's going to the grocery store alone, if it's going for a 15-minute drive, you have to do something to learn to take care of yourself, because like I said, if you're neglecting yourself, you can't be a caregiver for someone else. And there are tons of support systems and support groups. And if you join these support groups, there are other people there who are going through what you're going through, who will be able to give you tips and advice to help help you with this process, and to help give you advice. And you never know what you could learn from someone else who's already been through it. So it's really important that we reach out and that you ask your social workers for advice. And a lot of hospitals have their own support groups. So if you don't want to look out into a different organization, you could just ask your social worker, are you providing any type of service? And you'd be surprised how much is out there. So again, this weekend, I would take the time to go through these cancer support organizations that I've attached, and to really give each of them a look, and to give them a call, because they're all very helpful, and it will help you during this journey. So that's all I have to say. So I'm going to hand it back, but thank you.
Thank you for your presentation, Alexia, and for highlighting caring for the caregiver, as that is a meaningful role that is often overlooked. Cancer affects each population differently, and minority groups in the United States bear a greater burden for many cancers. The Florida Society of Clinical Oncology is actively fighting cancer disparities on many fronts. On your cancer journey, you can do your part by making sure you just ask. Help us narrow the gap. To learn more about cancer disparities in lung cancer, please download our Disparities in Lung Cancer slide packet and Minority Cancer Awareness handout located in the Handouts drop-down box on your GoToWebinar panel. We will now move on to the Q&A portion of the webinar. I'll read the questions, and then our panelists can decide who will answer each question. We will continue to ask questions that attendees sent in the chat for the next 10 to 15 minutes, then we'll move on to the final portion of the webinar. Panelists, go ahead and turn on your webcams, and I'll start with the first question. Okay. So the first question was, how quickly does lung cancer from early stage cancers turn to metastatic disease? I don't think we have a specific answer for that. Each patient is very different. We always hope that people with early stage lung cancers that we are able to give curative treatment, but we do know that some people will progress to metastatic disease. We don't necessarily have many markers that tell us who will be that particular patient. But in the early stages of lung cancer, we try to do things to decrease the risk of having persistent disease after early treatment and to decrease the risk of having recurrent disease after early treatment. That can include things like post-treatment or post-local treatment with chemotherapy, post-treatment with radiation therapy. And then a newer thought process is for people who have earlier stage cancers that, as Dr. Manishakian said, that we can find a targeted treatment to give that after initial localized treatment to try and decrease the risk of having something return. So I don't know if you have any different thoughts, Dr. Manishakian.
I wouldn't add much. It's the answer is we don't know. We know that cancer takes some time to grow, but the moving from one stage to a stage, I think it's a very good question because, as I mentioned earlier, half of the patient they're already at a stage 4. So not on your watch or the patient watch or my watch is patient sometimes is progressing from a stage to the others. But how long did it take before the diagnosis to get that stage? We don't know. It could be weeks, could be months, it could be years.
Okay. The second question was, do you feel there's a strong enough emphasis on research and development of innovative treatments for metastatic lung cancer as opposed to earlier stages? And I'll let you go first, Dr. Manishakian.
Thank you. Yeah, very good questions. Yeah, I would say the emphasis, now you asked me and Dr. Johnson, we're always looking for more. We always would like to see more research happening. We always like to see more resources and support, from government, from other, companies. But we're definitely better off where we were years ago. A lot of excitement, a lot of research happening. Now, to answer the question in particularly, do I think there is more emphasis on different stages? I don't think so. I could be wrong. That the research basically is looking into mostly there is research that is dedicated to the earlier stages, such as newer surgical techniques, newer radiation modalities, and so forth, a new screening method, how we can pick up cancer early. But when it comes to drug development medication, it basically tries to cover all stages of cancer. In fairness, most of these drugs tend to be after they actually, show some activity in the labs, in animals, and it go through the phases of development. Most of the time, they are being tested first in an advanced cancer patient where there is an immediate need, and then slowly they could be moving on to earlier stage. But I wouldn't necessarily say there is more emphasis on more. I think everyone involved in cancer care, especially researchers and scientists, are trying to address cancer at all levels. Because as Dr. Johnson, I couldn't agree with him more, mentioned, I mean, if we are attacking cancer at earlier stage and preventing it from coming back or from spreading, that's by itself a success. So I think cancer research is already and will continue to actually address how we can help cancer patients across all stages, if you agree, Dr. Johnson.
I agree. So as I kind of mentioned a little bit earlier, if you look at the curves for how people survive lung cancer, since 2010, the number of people who survive and, as we say, live with lung cancer has steadily increased, okay? So as you said, Dr. Manishakian, this is a good title for the talk, because what we want to do with treatment is not have a sprint. We want to try and turn everybody's treatment into a marathon. So, the number of dollars that are spent for lung cancer research have been much lower than in some other cancers. But that's starting to change also over the last 10 years or so. And we know that a higher proportion of dollars have been spent on lung cancer research. Those dollars, as you said, cover the whole gamut of stages, cover the whole gamut of treatment modalities, and then questions on how you piece those together in order to give the patient the best treatment outcome and hopefully the least amount of side effects. Okay. The next one is actually for you, Alexia. So the question is, are there resources available to help with financial burdens brought on by COVID-19?
Yes, so there's actually a lot of organizations and financial resources and grants right now that are unfortunately are lacking funding because of COVID, so a lot of people aren't donating, but there are a lot more that have opened up to help cancer patients specifically affected by COVID. So if you go to cancer.net, they have a whole COVID financial resource page to help people with cancer. So there's Cancer Support Community Helpline, which is one of the organizations attached on the sheet that we have. The Family Reach has a COVID emergency fund, the HealthWell Foundation, and the Patient Access Network. So there's a few more out there, but if you go to cancer.net, they actually have a whole list of organizations that are helping cancer patients specifically affected by COVID.
Okay. The next question is actually a very tough question, but a very good question. So the next question was, when do side effects of chemotherapy and immunotherapy cross the line from manageable to concerning? Okay. Would you like to try that one first, Dr. Manishakian?
So a very good question, like Dr. Johnson mentioned. So we do have in the medical management of cancer patient a grading system. If I want to go by the book, we do any side effect, you name it, at least the most common side effect. We try to grade it. Now sometimes it comes just by default by a conversation, and sometimes we need to dig deeper. Someone is having neuropathy, the one we talked about, just giving an example, or which is pinching of their nerve, tingling, numbness due to chemotherapy or other drugs. Okay, the patient come and say, I'm feeling some tingling, numbness, feel it in certain times. We have a good communications by ask, is it affecting your day-to-day activity? Is it very hurting? Do you need pain medication? And so forth. So we try to dig deeper, get a good medical history of that side effect, and then we put our judgment, our medical expertise along with the patient. It doesn't always work to say, you know what, this is at a grade 1, 2, 3, 4. We ask the patient. I mean, the patient is actually the best, knows their body more than the doctors, more than anyone else. Sometimes the caregiver come and say, you know what, is struggling. My sister is struggling. This is so much, doctor. And so we try to come up, is this something, back to the question, manageable? Can we do something to fix it or to help with it? If it's a nausea, the science, as I mentioned, has gone so far as having great nausea medicine. So if it's a high level side effect, but I'm able to help the patient and minimize it, then good, we move on. If it's very, very high, we don't even just think about adding medication, we may have to stop the chemotherapy or lower the dose of these drugs. It's so much science of the toxicity management of these drugs. I wanted just to give an example. It's not written in stones, even though we have some guidelines. I've seen, and everyone, last thing I want to mention, last point, everyone is different. I have patients, their tolerance is so high where they say, doctor, I'm mentioning it to you, but don't worry, I'm actually more than okay. Of course, we all know the spirit of our beloved cancer patient, they're fighters. So this is our job also to make sure we're not letting them suffer. Most patients tend to tell us, look, doc, this is too much, what can we do? Or some would say it is mild. But I've seen patients telling me, no, I'm told I have neuropathy, I'm used to it, please don't make major things. And I have patients with a very mild neuropathy telling me, our life changed forever, please do something about it. Dr. Johnson?
Yes, I agree with everything you said. So I think what can go from manageable to concerning, like you said, there are some specific things that we know when we have our dialogue with the patient, that those are concerning things and we need to make alterations in treatment, or we need to maybe hold the medication or adjust the medication. But as you said, everyone is very different. So I would say to that, make sure you, as a patient, feel free to have open dialogue with all your caregivers. That gives us the best idea for you, what is manageable versus what is not tolerable. And it gives us good information on where we need to make changes to, make your journey the best that it can be. All right. Okay. The next one is, can you speak to any clinical trials that are currently ongoing that you think are promising? Okay. So I'll try and go first on this one. There are always quite a few clinical trials. Not to go into too much depth, some of the clinical trials that I think are promising, one would be, again, trying to do things to help your own immune system help you out, okay? So that can come in many different fashions. One of the clinical trials that I'm hopeful will have some good results is try and make it user-friendly in the description. But basically, taking a piece of your tumor, using your tumor to prime your own T cells so that your T cells have a more specific target to try and hit, giving you back your T cells, and then hopefully those lymphocytes, which are your white blood cells, will hopefully infiltrate the tumor, go into the tumor, and hopefully kill off the tumor and give you some good response. So kind of the same thought process that you would get with the immunotherapy, but hopefully giving the T cells a bit of a more specific target. I'm hopeful to have some good results on those types of studies. It's also hopeful that, as you said, you can reduce a bit of the toxicity of treatment by making it more specific to that particular person. Other studies would be, again, along the thought process of using your own immune system is, as Dr. Manishakian said, people develop resistance to immunotherapy, or tolerance, I should say. So what kind of things can we do to reprime the immune system such that you may be able to get the immune system to start to respond to the cancer again? So studies where you give some type of immunoadjuvant that hopefully restores your own body's immune system recognition of the cancer. And so hopefully you would be able to continue along the lines of immunotherapy, but reprogram the body such that you can make a secondary response after you've had some tolerance to the initial immunotherapy. And then maybe other than that, combining targeted agents with other things to see if you can improve that response and make that response more longer lasting. So I think those would be the kind of studies that I would have the most hope for, and I think are going to be more promising. Okay, Dr. Manishakian.
I agree with everything you mentioned. Again, without going in so much depth, there's so much out there. What Dr. Johnson mentioned, these are very innovative approach to attack the cancer, and we're so looking forward to them. A couple of other quick things I would mention. Again, just in the targeted therapy, well, discovering more targets. There are a couple of targets that are an actionable mutation that don't have an FDA approval, but they're very common, such as something called KRAS, is actually already looking very promising in trial, and it's in the late phases, where I expect in soon, hard to tell when exactly, we will have drugs. And then I'm looking forward to more science and discovery of these actionable mutation or personalized driver of cancer. And then the last thing I would mention also, back to one of the very good questions that came early and Dr. Johnson covered, is early stage cancer. So, there are some actually very good trials right now testing the drugs that we already know working well in advanced stages, such as the immunotherapy we talked about, in early stages, such as patients who have an early stage need to go for surgery, but their tumor is kind of in a very complex area where surgery is not doable, or they undergo surgery, but yet after surgery, their cancer starts growing again. So we have some already preliminary good trials that show that if we actually give these patients, some medication prior to surgery, which is something very established in other cancers, such as breast cancer, is actually very promising. And I do expect in the next few years, again, not newer drugs, some drugs we already know we're using in later stages, bring them sooner alone or in combination of chemo. Active trials are accruing now with some very good preliminary results telling us that these are going to be effective treatment to give to patients before surgery, or turning some patient who may not undergo surgery and render them to be able to undergo surgery again, which hopefully can give them long-term survival and cure the cancer when and if it's diagnosed at earlier stage.
Okay. All right. So that was the last question that was posed from the chat box. Are there any other topics or points that the panelists would like to make before we move on?
I just want to say one more thing. I think, as you said, Dr. Johnson, it's really important for caregivers to, if you can't attend the appointments, to at least call in when your loved one is there, because caregivers can see things that sometimes the patients can't. So sometimes as caregivers, you can see if your loved one's a little disoriented, or maybe the medication with them isn't sitting well. And it's very important that instead of stopping taking your medication, you contact your doctor immediately. It's a huge problem that we have, where people just stop taking one of their medications because it doesn't make them feel well, but it affects everything else. But if you communicate with your doctor and you communicate with your team, they could help try to prescribe you a different medication to help with your side effects. That to me is a huge issue that we always have with medication management. Pill boxes are very helpful to help keep everyone organized. And I think it's just really important, like I said, to contact your social worker and to reach out to finance, because those are social workers can help you with your social issues, your home issues, transportation and medication, and finance can help organize you and help you with your insurance issues. So those are two really important teams that are in a hospital, and there are other organizations just like Flasco that are out there to help provide support, financial resources, and grants.
A great point, Alexia. I just want to add to that to say yes, because the psychosocial aspect of fighting cancers are very, very important, and sometimes are daunting as much as the physical symptoms. So patient needs to know that there are these resources. One thing I didn't mention, I would like, because I don't know that we don't get always the chance to cover that topic, is most of our centers actually including what we call, and encouraging to include what we call, palliative care in management of advanced cancer patients. And it's something I highly emphasize. It has changed significantly over the last 10 years. I know there are some people listening out there who still hear the word palliative and they get nervous because they think of palliative care as a hospice care, which is a very good care that we usually reserve for patients who are no longer on aggressive cancer treatment. But palliative care is actually, it may be run by the same, team or folks, but palliative care is not end-of-life care. Palliative care is actually how to, optimize symptoms management, how to live with cancer. We cannot let this, webinar go without mentioning that, we as a provider, we tend to fight aggressively. We throw drugs. So we actually use the help of the palliative care to help the patients, manage the symptoms of the cancer as well as the symptoms and the side effects of these medications. So a lot of research has shown, including palliative care team or symptoms management team, and seeing the palliative care specialist or provider as early as possible in stage 4 cancer or even earlier stages actually has improved not just quality of life, but even actually prolonged life. I still, until now, when I tell the patient I want to call palliative care, I get a call the next day from some patients say, why are we giving up? No, we're not giving up. And of course, the ASCO, Flasco, all the great providers, the panelists, we've done a very good job in education, but I try not to let an opportunity go without mentioning is that palliative care means actually, fight the cancer better, and including physical and mental and, symptoms.
I 100% agree. And just for Alexia's last point, the caregiver sometimes is my best medical assistant as far as helping me figure out what's best for the patient. And I certainly concur with you about retooling the name palliative care such that people recognize that it is symptom control. And a person who has good symptom control, their quality and quantity is greatly improved. So, all right. So that was our final question. Panelists, thank you for answering these questions and sharing your expertise with us. Our last presentation has been pre-recorded for this program, but unfortunately, due to technical errors, we are unable to view it on today's webinar. We apologize for this error. It will instead be emailed to all attendees after the webinar. It is a very important discussion regarding patient advocacy, access to quality care, pharmacy benefit managers, or PBMS, and additional support resources made available through the Flasco patient portal. We encourage all attendees to watch it. If you would like to be added to our mailing list for patient advocacy, please email info@flasco.org. I'd like to thank all of our panelists again for presenting this evening and leaving us with this meaningful information. I'd also like to once again thank Foundation Medicine for sponsoring this webinar. After such an important discussion, I'm sure we've all walked away with something new that may positively impact our practices. As a reminder, all of the handouts mentioned in this webinar can be found in the handouts drop-down box on your GoToWebinar panel, so make sure to download them now. Additionally, this webinar was recorded, so if you missed anything and want to hear it again, it will be available on the Flasco website soon. Thank you for joining us tonight, attendees, and we hope you all will join us for more webinars in the future.
Hello, I'd like to welcome you to the advocacy portion of our Flasco Living with Cancer series presentation tonight. My name is Michael Diaz, and I'm a medical oncologist and hematologist. I'm the Flasco Director of Patient Advocacy and a past president of Flasco. I practice medical oncology and hematology in St. Petersburg, Florida with Florida Cancer Specialists. And we're here today to talk about something that's pretty near and dear to my heart, and it has to do with patient advocacy. And so first of all, I'd like to start off more from the big picture perspective. I've had people tell me in the past, well, Mike, talk about advocacy. Tell them what it means. Well, I looked up the definition of advocacy in the dictionary, and all it says is to advocate. Very helpful, huh? So let me just explain. So advocacy, as far as I'm concerned, yeah, it's a general concept, but it means to advocate for, which means you're trying to do something to benefit somebody, whether it be yourself or somebody else. In fact, you all being here tonight to educate yourselves means you're advocating for yourself in the form of education, educational advocacy about a condition that might mean something to you or someone you know or care about. So yes, there's educational advocacy. Your doctors will also most likely advocate for you whenever they're fighting insurance companies to get scans or medications or therapies or testings approved. We really don't get paid any money to do that, and that's we either have to hire staff to do that or we do a lot of it ourselves too, but we're advocating for you. The way, and there are many other ways besides education, you can advocate for family members. You can help assist with certain components of their care, and all that is advocating. And there are lots of ways to do that. The main way that I like to advocate for my cancer patients, because that's one of the reasons why I love being a doctor. In my free time, which is not a lot of, but I do spend a lot of time doing it, is I advocate for my patients when it comes to healthcare reform. One of the things that I noticed as I was going through my training as a young oncologist is that it didn't seem to me that there were a lot of healthcare providers involved with the policy decision-making process that would impact patient care, patients' healthcare, or their access to care. And one of the things that I've been doing since I've been practicing medicine for a little over 15 years now, I've been getting more and more involved with advocating for healthcare reform so that patients have access to affordable quality healthcare that's close to home. I'm a firm believer that we have enough resources in this country. There's no reason why people shouldn't have to spend their life savings or refinance their house just to get their cancer care. I think it's ridiculous. I personally think that the system is flawed in a lot of ways, and I think that there are a lot of people who are getting a disproportionate share of the resources, and those are not the patients, and I personally don't think they're the providers either. So that's one of the reasons why I'm involved with healthcare reform. And we do it in a lot of ways. I work with organizations of like-minded individuals, whether it be other oncologists or pharmacists. We have organizations. We work to advocate here in Flasco, mainly at a state level and also at a national level. But I do work with other organizations for synergy. And it all has to do with in understanding the healthcare system, which is extremely overly complicated. It needs to be fixed, but it's what we have, and we have to understand it to understand where the problems are so we know where we can fix things. So If we need to, instead of guessing, we will perform studies or commission studies to be done to better understand the little nuances of how potential things are impacting patient care or access to patient care. And then we also spend a lot of time educating our elected officials on this process, whether it be local in Tallahassee, whether it be going to DC, which we don't do a lot of traveling now, but I previously I would go to DC at least twice a month to help educate our elected officials there. We have to network a lot with Health and Human Services as well as Center for Medicare and Medicaid Services. And at a state level, we have to work a lot with the governor's office, the insurance commissioner, as well as Florida Medicaid for a lot of patient issues. And just to give you an idea of how effective you can be sometimes, for those of you all that aren't aware, about 4 years ago, the previous administration attempted a demonstration project that we will call the Part B Medicare Demonstration Project. And they thought, oh, we're going to save money. We're going to reduce the cost of care. And unfortunately, all it would have been doing was restricting access of care to possibly 50 to 75% of Medicare patients across the country, because it basically refused to pay for the more expensive treatments. Well, if you have cancer, you know that a lot of the time, the most effective treatments are the more recent treatments and are going to be the more effective treatments. Well, they were going to try to encourage you to use more generic medications. Well, the generic medications in cancer care are over 10 or 15 years old, and they're fairly outdated and not usually as effective as the newer medications. So it would have negatively impacted patient care. We went to grassroots across the country. We had to have all of our patients contact their representatives and their senators and tell them that they needed to shut this down. We were very successful in that it never took place. In fact, the following year, I went to meet one of our senators' healthcare aides, and she said, you don't need to introduce yourself to me. Because of you, I had over 3,000 emails in my inbox. My email was locked. My email account was locked for several weeks. She said, you did a great job with that. The senator wasn't listening to me, but when he saw how many people were concerned about this project, he said he realized he had to listen. So we can work together, and we'll talk more about that. I would like to move the discussion onto a more timely, more relevant, more current issue, which is known as pharmacy benefit managers. And most people aren't aware of even what a pharmacy benefit manager is. And just to give you a little background, the pharmacy benefit managers are who your insurance companies hire to manage your oral prescription benefits. They started off as just claims processors back in the 80s and 90s. All they would do is process insurance claims for oral medications. Well, over time, they evolved, they coalesced, they merged to the point to where there are essentially 3 pharmacy benefit managers that manage the oral prescription benefits for nearly 80% of all Americans. That's a lot of control and influence. Well, what happens when you have this control and influence? Stay tuned, we'll talk more about that. But these pharmacy benefit managers are so lucrative from a business perspective that they are merging with the top largest insurer companies in the country. In that one of the largest pharmacy benefit managers, CVS Caremark, recently bought one of the nation's largest insurance companies, Aetna. Well, 3 of the largest pharmacy benefit managers are owned or own some of the top 4 largest insurance companies in this country. So there's a lot of vertical integration going on. And it's because this component of healthcare has become so profitable. It's like, well, why has it become so profitable? Well, these pharmacy benefit managers, and more we're learning about this. In fact, this gets us to something that's near and dear to my heart, the price of drugs. I think the price of drugs are crazy. They're astronomical. They're very high. And it's difficult for patients to get their care because these newer medications and treatments cost so much. Well, studies are showing that when it comes to brand name drugs, we don't even talk about generics. It's a lot more complicated. Brand name drugs, probably well over 50% of the cost of any drug, whether it be oral drug or IV drug, over 50% of that is going to somebody else as a rebate. Yes, over half the cost of drugs. So if you're on a drug that costs $1,000 a month, over $500 of that is going to a rebate in somebody else's pocket, not the pharmaceutical company's pocket. So a lot of people like to complain to the pharmaceutical companies about drug prices, and I'm not letting them off the hook. But when I meet and I talk with a lot of the senior national executives in pharmaceutical companies, and they're aware of my stance that drug prices are too high and they need to get them under control and they need to do something about it. But part of the reason why the costs are so high is because of these rebates that are given out. Well, these rebates are from the drug companies, but they have to be built into the cost of the drug. And one of the nation's largest recipient of rebates are these pharmacy benefit managers and or insurance companies. Yes, the U.S. government via Medicaid and the VA healthcare system, they get some rebates. And they are a decent sized percentage of those rebates, but nowhere near as large as the rest of the rebates. In fact, some studies are showing that well over $150 billion a year in 2019 dollars was spent on rebates. And that's one of the reasons why the cost of drugs are so high. And when I talk with the senior people in pharmaceutical companies, they are somewhat traumatized after they have discussions with these pharmacy benefit managers because they have to talk with them and set up contracts before the pharmacy benefit manager will make their new medication available to the lives that they cover. And this is a typical comment I hear about that a pharmacy benefit manager would tell a pharmaceutical company. Wow, we really like that drug, your new drug. It's great, and we'd love for our patients to have access to it. But they need to know that we're working for them. So up front, we want you to give us a 10% discount off of the price so they can see we're working for them. And then after they've paid their copay, and after all the claims have been processed, on the back end, we want a 50% rebate. Otherwise, they will not even know your drug exists from us. And so these guys, they want their drugs to be available. And like I said, 3 of the largest pharmacy benefit managers control nearly 80% of the prescription benefits. If you don't let them have what they want or some version of it, your drug's not going to see a lot of patients or not even have the possibility to be used for a lot of patients. And so there's definitely an issue with the rebate system going on, but also on the other end, the pharmacy benefit manager will also go after the providers. When I say the providers, the pharmacists, or in the case of cancer patients, if the cancer doctors are providing the drug, even the oncologist. They like to come back to us about, months after the transaction occurred, i.e. the prescription was given, and they'll just come back and say to the provider, either the cancer doctor or the pharmacy, and say, yeah, you owe us 10% of all this money. And it's like, why do we owe you 10%? So, well, you didn't meet quality measures. And this is exactly what was told to my practice. You didn't meet quality measures. Like, we didn't know that there were quality measures. They said, well, you're correct. There's not any oncology or cancer specific quality measures. So, we looked at the cancer patients that you're taking care of, our cancer patients that you're taking care of, and we looked at their adherence rates to blood pressure medications, diabetes medications, and cholesterol medications. And well, they were all perfect and they were adhering to the medications. So we couldn't use that data. So we looked at the entire Southwest Florida regional adherence rate to blood pressure medications, to diabetes medications, and cholesterol medications, and we applied that to you. And because the compliance rate in Southwest Florida is not very good, you've got to pay this penalty. And, my people know that if we don't pay this, what's called a DIR fee, direct and indirect remuneration fee, then we get kicked out of network. We can't take care of our patients. And trust me, if we can provide the oral medications to our patients, they will have much better patient care than if it's provided by some third-party specialty pharmacy that's nowhere near here, that knows nothing about patients or patients' care. So we do what we can on our end to try to sustain those fees. But those are just examples. Now, that's how they affect the business end of the thing. That's how they affect the pricing end of the thing. But in order for these pharmacy benefit managers to make more money and to steer more traffic towards certain products, they develop these formularies. And these formularies are, I guess you could say, their versions of preferred drug lists, and that drugs that they like, and some might even say, yes, that might be the appropriate indication for the drug, but Are they getting higher rebates on this drug and that's why they like it or not? We don't know. All that information is privileged and considered to be proprietary. But they have these formularies, and we're seeing perfect examples of how these formularies that they're trying to implement on cancer patients, they don't really work. You have cancer, you know that you may have other unique healthcare conditions, and it's not like there's a plethora of medications with which you can choose from, which some might consider to be your best treatment option. Why? Because different medications have different adverse side effects, and some may have an adverse side effect profile that may be detrimental to you given your unique health characteristics, or may not be better for you given your unique cancer. And so it's very difficult to say that just because I have cancer and it is cancer type X, that you should always start off with this one medication that these pharmacy benefit managers are saying you should start off with. And I can give you a perfect example. Let's tie it into patients. One of the things that we do is that we collect what's called patient PBM horror stories. And I do want you to know, if you have had any of these horror stories, as I will be talking about in a minute, please type in the little text box your name so that we can, and the best way to reach you so that we can reach out to you at Flasco and get your horror story recorded. We do this at the Flasco level. We do it at a national level. I do it with a national organization I work with called Community Oncology Alliance. If you go to pbmabuses.org, that's P as in Paul, pbmabuses.org, you can see, unfortunately, volumes of horror stories that have resulted from these pharmacy benefit managers negatively impacting patient care. Just to give you an example, getting back to the formularies that we were talking about, we have several examples that have even happened here in Florida where a patient with a condition and other cancer and other medical conditions, for example, like bad kidney disease, should be getting, if you look according to routine formularies and what's considered to be the #1 line of therapy, a medication that its #1 side effect is that it can impact the kidneys. Okay, well, one of my partners saw this patient and realized, wait, this patient needs this medication. It could impact the kidneys. They have bad kidneys. Then maybe we need to start them on the second line medication first, period, and avoid this potentially more dangerous one. They sent the patient to a local cancer center of expertise, and their specialist in this cancer said, yeah, you can't have that #1, that first drug, that first medication. You need to start off with the one second on the list because it could hurt the kidneys. Well, it took the pharmacy benefit manager over 2 months to approve the medication because it was denied because it wasn't #1 on their formulary list. So we have several examples where they can delay access to timely care. We even have examples nationally of patients just dying while they're waiting for their medication to arrive. An unfortunate example of a patient who waited 9 weeks for a routine metastatic breast cancer medication to arrive, but the pharmacy benefit manager fought with the provider for so long, the patient gave up after 8 weeks, went into hospice. The medication showed up just after that, but the patient was too weak to even take the medication. We have other examples of where the pharmacy benefit manager, I have 2 examples in my practice, not with me, but with 2 of my partners, of where the pharmacy benefit manager actually said, no, we know this medication is frontline and is the first one that's listed to be used, but we think the patient should have surgery first. And in both instances, even the surgeon and the medical oncologist said, no, surgery is contraindicated in this patient. They said, well, no, we think the patient should have surgery first. So they're making a medical decision without even seeing the patient. They're making a medical decision without a license to practice medicine. And that's one of the things they're doing to save money and to help their bottom line. These guys are businesses. They took an oath to their shareholders. They did not take an oath to patients like the doctors did. And so if you have a horror story, please type it in on the question box so that the people from Flasco can contact you, hear your horror story so we can get it documented. We need to have these documented. And part of the reason why is that we are working on trying to reform the healthcare system as far as these pharmacy benefit managers are concerned. We're working both at a state level and at a national level. To give you an idea of what we've been doing at a state level, in fact, we've been coordinating with other healthcare advocacy organizations, And we attempted to have legislation passed last year for pharmacy benefit managers. It would have held and made sure there was transparency as well as accountability, because right now there's no transparency. I was in DC a couple of years ago and was talking with some key staffers on both the Senate and the House, and they said, yeah, the pharmacy benefit managers people were up here yesterday and they were lighting their hair on fire saying, oh no, we can't be transparent. That will disclose proprietary information. We won't be able to save money. There's no way we can be transparent. Well, you know, this is healthcare. Everybody needs it. And if you have to be that transparent, then is there a reason for that? So we want reasonable transparency and we wanted accountability. And unfortunately, that bill did not pass. It did not go up for vote in the House or the Senate, but we will be working on that again for next year. And that's one of the reasons why I want to grab your attention. We will be working on that next year, and we will need your help with reaching out to your legislature, your state representative and your state senator, so that they will know they need to support this bill. Now, with that being said, to give you a little bit more of an idea of how conniving these pharmacy benefit managers can be, one of our other organizations developed a study looking at Florida alone, just to better understand how these pharmacy benefit managers worked in the Medicaid system that's run by the state. And just in one example, with a generic medicine, they saw that the pharmacy benefit manager was paying a pharmacy that they didn't have a preferred contract with. They're paying this pharmacy approximately 20 cents a pill for generic medicine the patient needs to take twice a day. And they were paying a pharmacy that they had a contract with. Now you got to keep in mind, this contract that they have with the pharmacy is not accessible to the public. Why? Because it's proprietary. Well, they were paying them $10 a pill. And when you sit down and you look at things, it would not be reasonable, given the fact this medication is taken twice a day, every day, within a year, if you assume a reasonable number of patients are on this medicine, it's a commonly used medicine, very commonly used medicine, that it wouldn't be reasonable for there to be a $30 million discrepancy going into this preferred pharmacy's pocket. So that has caused a lot of uproar in Florida. That was not able to get this legislation passed, but it was able to get the governor to hire a nationally renowned actuarial firm to do their own study to validate and verify what this other study has seen. If there's that large of a discrepancy, then if it's the taxpayers' dollars, I think the taxpayer deserves to know, why is this pharmacy getting paid so much more for pill than your average pharmacy? Okay, that stuff needs to be known. There's been a lot of reform going on at the state levels because of little tactics like this, especially in Florida, especially in Ohio and Georgia. We want Florida to be next, and so we'll be reaching out to you to advocate more next year. We're also working at a national level in DC with a couple of different bills, a couple of pieces of legislation, one so that patients could get their drug within 48 hours and they wouldn't be waiting several weeks or even months to get their medication. Now, some of that stuff's been put on hold because of COVID, but we plan on bringing that up at the beginning of next year, because right now, with the way things are in DC, not a lot's happening at all within the next several months because of COVID, because of the elections, but we are working on it as we can. So your involvement is essential. As I told you with the example, when it comes to healthcare reform, if your elected official hears about you, the voter, and they hear that you are concerned, they will listen. And we are planning on this next year, for this next 2021 legislative session, we are planning on having a bill introduced to help reform pharmacy benefit managers. But we need to have a coordinated effort, because there might be more than one bill out there. We want to make sure that you are sponsoring the correct bill. We want to make sure that you know why. So it's a good idea, I think it would be, if you are interested and want to help verbalize your opinion as a voter to your elected officials, that you put your name and email in the question box let them know you want the monthly newsletter. It's a monthly patient newsletter. That's one way to stay updated. Not only will you learn about advocacy issues, but you will learn updates about all the different things that we talked about today. And just as well, you can go to the website at www.patients.flasco.org to learn more about not only advocacy information, the things that I'm talking about here today. Once again, it's to make sure there's a coordinated effort so that you know when to reach out to your elected official, you know what to talk about, you know which bill to tell them they need to support, but it's also to learn more about other things for patients, such as assistance programs, various support groups, as well as clinical trials, and yes, of course, something important and dear to me, information about advocacy. And also, we plan on notifying all the patients that have participated in these Living with Cancer series when there is a time we need to call them to action, because you can help us, the providers, make sure that you have access to care that's affordable, quality, and that people are not taking all the money that's being designated for healthcare, instead of it going to the patients, they're putting in their pocket. We got to put a stop to that. So I appreciate your attention, and please sign up for the newsletter, go to the website. Any questions, once again, please direct them in the question box. Your questions will be answered, but you all have a great evening. Thank you. God bless.